Sorry. Now, we have to deal now with a patient, a 58-year-old male with body mass index of 36 kilograms per square meter, dyslipidemia, and elevated aminotransferases. So we have a patient of total cholesterol 245 milligrams per deciliter, with HDL 35 and LDL at 170, and triglycerides 200. So we have a typical patient with metabolic syndrome. Also, this patient presents with a glucose of 105, a urea of 30 milligrams per deciliter, creatinine 0.9 milligrams per deciliter, and elevated, as we said, liver enzymes, an AST of 55, an ALT of 86, with a gamma GT of 90. So this patient also smokes 10 cigars per day for 35 years. He's an infrequent alcohol user, so we kind of exclude the alcohol as the cause of, let's say, his liver problems. And we test him. Our next move is to test him for hepatitis and other causes of elevated hepatic enzymes. And these tests proved negative. So now we think our basic way of thinking is that the cause of this patient's elevated enzymes, hepatic enzymes, is his BMI, the fact that he is obese, and the fact that he has very high lipids. So what do we do next? We proceed to perform a liver ultrasound, and the liver ultrasound proves to us that the patient really indeed has, let's say, we have a patient with non-alcoholic fatty liver disease, and then our next step is to, let's say, to find out if the patient also, apart from the level of high lipids, also has a level of fibrosis. So we now have, let's say, to determine the FIB-4 score, which is 2.15, which shows an indeterminate level of fibrosis. And then we have to refer this patient for fibroscan, which proves to us that the patient has a medium level of fibrosis. So let's see what is actually the non-alcoholic fatty liver disease and the non-alcoholic steatohepatitis, which the two together comprise a unique syndrome, a syndrome with clinical and laboratory parameters, which the main feature is a broad spectrum lipid infiltration of the liver. And when we have a liver infiltration, this has to be over 5% of the liver so as to establish a diagnosis of non-alcoholic fatty liver disease. We have, of course, to exclude the use of alcohol, which is at least 2 alcoholic beverages or less per day, and also other causes of steatosis. What we mean by other causes of steatosis, causes of chronic hepatitis. Now you see here that if we project our, let's say, the findings, which are the people worldwide that have a non-alcoholic fatty liver disease, and we see now that these people are so many. We project to the immediate future in 2030, we see that actually the incidence of the disease is going to be, let's say, is going to multiply by 72% in the United States and Canada, 148% in Latin America and Caribbean, 32% in Europe. In Africa, it's going to be in a level of 162%, and even 150% in Middle East and in China, 104% in China. So we'll see that people are going to have more and more fatty liver disease in the world in the next few years. And this is a serious problem. We have to see what we're going to do about it. And why we are so worried about this fact? Because as we see here, in the fatty liver, the fat accumulates in the liver, it causes inflammation, it causes scarring, and then the scarring goes on to produce fibrosis, and the fibrosis causes cirrhosis. So, non-alcoholic fatty liver disease affects up to 35% in adults, as we have estimated it, or nearly 5% of children. And of these, what non-alcoholic is in 5 to 7% at least of these people, it is going to proceed non-alcoholic steatohepatitis. Up to 20% of these people are obese subjects. And we see here the results of this non-alcoholic fatty liver disease and non-alcoholic steatohepatitis in the liver. What is at the beginning an infiltration of the fat with, let's say, lipid droplets. It then goes on with, let's say, inflammation. The inflammation becomes fibrosis. we have the typical ballooning, and then the fibrosis goes on to become cirrhosis. Now, there is here a very interesting overlapping as we see it. We have the typical non-alcoholic fatty liver disease, which is driven for, let's say, what we call the metabolic syndrome, the type 2 diabetes, the glucose intolerance, the high levels of total cholesterol, LDL, triglycerides, the central obesity. Okay, these are, let's say, typical features that we expect to see in a patient with non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. But also there is another factor, the genetic factor, that we don't, let's say, take it under consideration so much. The genetic factor is very important because many patients have non-alcoholic fatty liver disease without being obese, without having the typical metabolic syndrome. There are lean people that have non-alcoholic fatty liver disease. And also there is another thing, there is the overlapping, as I said before, because also diabetes and obesity and the cholesterol have also, let's say, a genetic factor. We have a genetic predisposal. We are genetically predisposed to have high cholesterol, diabetes, or obesity in many occasions. So we see there's an overlapping of these things. There's a genetic element in the things and in cholesterol, in diabetes, in obesity that call the metabolic non-alcoholic fatty liver disease, but also the metabolic fatty liver disease also in its part also worsens the genetic factor of non-alcoholic fatty liver disease. And how all these things goes on, how all these things is happening. Insulin resistance is the main problem. When we don't have, let's say, the right signaling of insulin on the adipose tissue, the problems begin. There is the beta oxidation, there is the production of free fatty acids, as we see here, and the production of many free fatty acids causes more defect in the insulin signaling, in the insulin signaling, and this promotes the apoptosis, the inflammation, a mitochondrial dysfunction, endoplasmic reticular stress, the adipose tissue dysfunction. More and more modificators of the inflammation are produced, and then we have all this cycle of inflammation which goes on to become steatosis and fibrosis. So how is the progression exactly of the non-alcoholic steatohepatitis outcome? The progression from non-alcoholic steatohepatitis to fibrosis is in 25 or 35% of cases. And in 9 to 20% of these cases become cirrhosis. In 40 to 6% of these cases, we have liver failure or cancer, hepatocellular cancer. And in some of these patients, we either the final outcome is death or orthotopic liver transplantation. And we see here now how fast does non-alcoholic steatohepatitis progress. Study using paired biopsies estimated an increase in one fibrosis stage every 7 years, and non-alcoholic fatty liver was estimated to increase by one fibrosis stage every 14 years. Now, how do we proceed with the diagnosis? We saw that we have perhaps to exclude other causes of steatosis or steatohepatitis. We have, of course, to do the laboratory tests, AST, ALT, the ferritin is always high, higher than normal, as an indicator of inflammation. The liver imaging, ultrasound, liver fibroscan, which is very important, also the liver CT and MRI, liver biopsy, of course, which is the gold standard. This is what really says the diagnosis, especially for steatohepatitis and fibrosis. And then we have the scores, the NAS score and the FIB-4 score. The FIB-4 score, what is the cutoff? The cutoff is 1.3. We have a cutoff 1.3. So after the 1.3, if we have a score over 1.3, we start to have different levels of fibrosis. And these are all first the scores, the clinical predictors of fibrosis. Then FALB fibrosis score, which uses age, AST, ALT, platelets, BMI, and albumin. The BARD score, the FIB-4 score, which uses age, ALT, AST, and the platelet count. And the presence, of course, of underlying risk factors, diabetes, hyperlipidemia, etc. Now, the non-alcoholic fatty liver disease, it's not just the problem with it exactly, with the liver, just the liver. It has a very strong relationship with what we call cardiovascular disease, and we see it here, with cardiac abnormalities, chronic kidney disease, polycystic ovary syndrome, psoriasis, liver-related complications, malignancies, osteoporosis, sleep apnea, abdominal obesity, type 2 diabetes. Because what is the reason for all of this? That there are molecular pathways that mediate the interplay among the liver, the kidney, the gut, and also what we call the heart and the vessels. And this is happening through the inflammation mediators. And we see here, for example, that the insulin resistance, when we have an elevated insulin resistance, and also an elevated, we have also, this results in atherogenic dyslipidemia, an elevation of the inflammation, oxidative stress, thrombophilia, and hypertension, which results in coronary heart disease and left ventricular dysfunction. And the result of all this, of course, is an elevated level of atherosclerosis, a heart failure. So we have, and what we see here more clearly is that non-alcoholic fatty liver disease is strongly related to cardiac hospital admission and to the survival of these patients, of the patients that have heart failure. So people with non-alcoholic fatty liver disease, let's say, were less likely to hospitalize, if we exclude all the other factors, was less likely to hospitalize for all cause, to hospitalize for cardiovascular events. When we have, let's say, a group with a larger marker of non-alcoholic fatty liver disease and a larger state of fibrosis, the possibility of rehospitalization and death of all-cause cardiovascular disease increases very much. If there is, let's say that we have a strong relation between the non-alcoholic fatty liver disease, the non-alcoholic steatohepatitis, especially as it goes on to become fibrosis, and the rehospitalization of patients with cardiovascular events and cardiovascular death. So now, the weight loss is very important. How do we proceed now to deal with all people, with these people that had, let's say, non-alcoholic fatty liver disease and non-alcoholic steatohepatitis? Actually, there is not, let's say, there are not specific guidelines. There is not, let's say, a specific treatment for these patients. So we know very well that there's not a specific treatment. We have, let's say, to try to treat with these patients with many different treatments. The first thing of all, the most important, is to have these patients lose weight. And all these, let's say, studies from a long time ago, they have shown that when weight is lost, we have an amelioration of the hepatic indices, and also, of course, with low-calorie diets, amelioration of the hepatic indices, but also a biopsy-proven improvement of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis and fibrosis. Now, metformin as the main, let's say, drug that improves the resistance to the insulin resistance, of course, is one drug that has been widely used to treat non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. There are many studies that try to establish, let's say, if really metformin is a good drug, is a good medication for non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. The thing is that most of these patients didn't include a large number of patients. As you see, there are only very small number of patients, only from 20 to 74 number of patients. even with let's say that problem, what we see is in every study, in every one of these studies, we had an amelioration of the hepatic indices, an improvement of the liver fat as shown in the ultrasound, and also in some of these studies that performed liver biopsies, we also in most of them also the histologic findings were improved. Now, pioglitazone is a very, let's say, also interesting case. There are it's from all the drugs that were used for non-alcoholic fatty liver disease, it's the one medication that was, let's say, best tried, and there are more studies concerning pioglitazone than with any other drug apart from metformin. The use of pioglitazone really showed an improvement of histologic findings with an improvement of glycemic and lipid profile and a reversal of inflammation. And we see here that even in patient, even if there was, let's say, a small increase in the body weight, because as we see, the pioglitazone is not good for body weight. The pioglitazone provokes an increase in the body weight. Even with that, the effects of pioglitazone in non-alcoholic fatty liver disease and non-alcoholic steatohepatitis were good, and we had, let's say, an improvement, an histologic improvement. So it's one of the medications that really are in every guideline regarding the use of it in non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. Also, the 4-dipeptidyl, the 4 antagonists, like alogliptin, with, let's say, the amelioration of glucose levels, have shown a kind of preventing non-alcoholic fatty liver disease progression in patients with type 2 diabetes. Of course, more studies have to be performed here. And then we go to the more, let's say, popular drugs of our days, the GLP-1 agonists. So there was a study, the LEAN study, a regulatory safety and efficacy study in patients with non-alcoholic fatty liver steatohepatitis, the LEAN study, that showed really that there was, let's say, an improvement in hepatic indices, along with, of course, the improvement of glycosylated hemoglobin, and also the level of triglycerides and in a lesser level of cholesterol. The thing is that it didn't show really, apart from everything else, it showed an improvement in non-alcoholic fatty liver disease, didn't show a histologic improvement. And then we proceed to another very, let's say, recent trial, which is a trial that brought new hope. A placebo-controlled trial of subcutaneous semaglutide. Semaglutide is the most popular drug of our time, non-alcoholic steatohepatitis. And these researchers used different, let's say, dosages of semaglutide, 0.1, 0.2, or 0.3 milligrams per liter once a day, controlled with placebo. And they showed when they reached the 0.4 milligrams of semaglutide, a 59% of hepatic amelioration compared to 17% of placebo. And we see here that there was an improvement of alanine aminotransferase and aspartate aminotransferase, but also there is a resolution of non-alcoholic steatohepatitis with no worsening of liver fibrosis. And in some cases, when we went to the higher levels, we proceeded to the higher levels of semaglutide, there was an improvement in liver fibrosis stage with no worsening of non-alcoholic steatohepatitis. And this was proven here with histologic findings. So we saw that there were very, let's say, very good outcomes with this study. But now, which was published in New England Journal of Medicine, but though there was a new study published in March of this year in Lancet, which was an even larger dose of semaglutide. Semaglutide 2.4 milligrams once weekly in patients with non-alcoholic steatohepatitis-related cirrhosis. This randomized placebo-controlled phase 2 trial showed no improvement in the fibrosis of these patients. It was really disheartening. and left us with many questions. Probably it needs more time. We're not sure about that. No more studies have to be let's say, we have to do more research to see what was the reason that a larger dose of semaglutide diet didn't have, let's say, the results that we've been expecting in patients with steatohepatitis and related cirrhosis. Now, VSD2 inhibitors also showed, probably because of their let's say, improving results in diabetes and in body weight, also showed some, let's say, hopeful results. And empagliflozin alone or in combination with linagliptin showed in mouse models an improvement in alcoholic steatohepatitis and diabetes. Now, let's see some results concerning the statins. So we have this study here, which was a post-hoc analysis of a study performed here in Greece, in our country, of safety and efficacy of long-term statin treatment for cardiovascular events in patients with coronary heart disease and abnormal liver tests, the Greece study. And what this study showed, the post-hoc analysis of this study showed, that the cardiovascular relative risk reduction was strongly related with also an improvement of the hepatic indices. And also the assessing of the treatment effect metabolic syndrome without perceptible diabetes, the ATTEMPT study, showed also that there was a safety and improvement of the indices of the metabolic syndrome and alcoholic fatty liver disease in patients which were treated with statins. The ideal study also, which let's say compared atorvastatin 80 milligrams per day and simvastatin 20 milligrams per day, showed, let's say, that especially with atorvastatin, the results were even better, that the use of the statins improved the fatty liver disease. And now there's also another study here, the resolution on alcoholic steatohepatitis by rosuvastatin monotherapy in patients with metabolic syndrome, which also showed with histologic findings that the use of rosuvastatin improved the cholesterol levels, of course, and triglyceride levels, but also the hepatic indices, and proved that with the biopsy, which showed a histologic improvement. And what we saw here, that we have also a very high degree of resolution of non-alcoholic steatohepatitis by use of rosuvastatin. There are other studies that showed that the statin use can improve the cardiovascular risk and at the same time the non-alcoholic fatty liver disease. And this is a study that was performed in our hospital, in the military hospital in Thessaloniki, that we used 3 different statins, atorvastatin, pitavastatin, and rosuvastatin. And we showed that, that the 3 of these statins managed to improve the lipid levels, but also the NAS and FIB4 score, and to improve also the hepatic indices and the scores of non-alcoholic fatty liver disease and alcoholic steatohepatitis in those patients with 3 different statins that showed similar results. Now, there are many drugs that now are, let's say, in the research stage. We're going to have many new, let's say, many new drugs in the years to come. We're waiting impatiently to see that. And also, we have also to mention that the bariatric surgery is an option in patients unresponsive to lifestyle changes and pharmacotherapy, because it reduces weight and metabolic complications. It has stable results in the long term. And also, the non-alcoholic fatty liver disease cirrhosis is one of the top 3 indications for this kind of treatment. Now, what we have to do now with our patients, of course, so as to proceed and finalize our presentation, is that we have, let's say, to establish his cardiovascular risk. So we have now with these type tables, so we'll find out that we have a very high risk patient, and we have to, let's say, to pursue a goal of less than 55 milligrams per deciliter of LDL cholesterol. So how do we proceed with this patient? Weight loss, rosuvastatin of 20 milligrams with escalation to 40 milligrams and ezetimibe 10 milligrams per day to reach the level of less than 55 milligrams of deciliter, which is the goal for very high risk cardiovascular risk patients. We also added pioglitazone 15 milligrams a day, and we saw an improvement of all his indices, the cholesterol and the hepatic indices, and which was also proven by US, by ultrasound and histologic evaluation. Thank you very much.